Good afternoon. I think people are filtering in here. Just want to welcome everyone to the third of three webinars on the Behavioral Health Centers of Excellence, COEs. My name is Michael Uliberry, and I'm the section chief of the BH Connect Section 2. That's in the Special Medi-Cal Projects branch, and it's in the Medi-Cal Behavioral Health Policy Division at the Department of Healthcare Services, DHCS. During today's session, DHCS and Health Management Associates, HMA, will be providing a high-level overview of the Children and Youth Behavioral Health COEs and their training and technical assistance approach to each evidence-based practice, EBP. In addition to DHCS and HMA, we want to acknowledge the MANAT team as a key collaborator for DHCS as policy consultants that support the intersection between the BH Connect and the Behavioral Health Services Act BHSA initiatives. If you have any questions during today's session, please feel free to leave your question in the Q&A feature at the bottom of your screen. And with that, I'm going to pass over to Patrick Metters with HMA to begin the presentation. Thanks again for being here and for your attendance.
Thank you, Michael. So my name is Patrick Metters. I'm an associate principal with Health Management Associates. HMA is an independent national research and consulting firm with expertise in multiple disciplines, including behavioral health. DHCS has contracted and partnered with HMA as the Behavioral Health Center of Excellence administrative entity. Just before we get started, we do have a few housekeeping items we wanted to make sure everybody is aware of going into the presentation. We are going to be recording this presentation and making it available on the Behavioral Health Centers of Excellence Resource Hub. It'll be there following this call. The recording and slides will also be sent to those who attended via email. Just as an FYI too, given the amount of information that we're going to be sharing as a part of today's call, we're not going to be able to answer questions live. However, I did not want that to discourage you. Please go ahead and place any question you may have in the Q&A portion of this Zoom call. If you're wondering where that is, if you look down towards the bottom, you should see a Q&A button. If you do not, click on More, and you should see the Q&A function that's underneath that. We will be tracking and logging all submitted questions that come from this group and ensure that you have written answers and additional information that will be provided to everybody who attended. In addition, we will also be collating any questions that come from today's call and include them on our question and answer session next week. As a reminder, when you registered for this particular webinar, you also received an invite for the Q&A portion that will happen next Thursday at 1 o'clock. So please make sure you put any question that you may have as we go through the content of this presentation, and we'll make sure that you have an answer to that by the time we have our Q&A session next Thursday. Next slide. So today we have a lot to cover. The primary focus of today's discussion is going to be looking at an introduction and overview of the Children and Youth Centers of Excellence. We'll hear from MST, we'll hear about FFT, and we'll hear about PCIT. At the conclusion, after we've heard from the COEs, we'll also walk through how counties will begin engagement with the Centers of Excellence, as well as next steps and additional questions. I think that it's also important for us to realize there are a few things that are out of scope from today's conversation. We are not going to be covering anything related to policy guidance on fidelity requirements for each of these EBPs, any billing related questions, as well as data elements and reporting requirements. Additionally, we should also highlight the high fidelity wraparound will also not be included in this presentation, but additional guidance on high fidelity wrap is forthcoming. So any questions that are submitted in those rounds, we won't be able to answer at this time, but just know that additional guidance is forthcoming on bins and policy guides that are going to be released by DHCS. In addition, I think it's also important to understand the role of the Center of Excellence. The COEs are really established by DHCS to support the counties and their contracted practitioners in really delivering high quality care. The COEs do not have a role in compliance, though they may advise the state and provide some input on training and technical assistance, as well as monitoring requirements to really support these standards. But DHCS's role is really to set and enforce compliance to the policy. Next slide. So I do want to provide a quick overview and introduction to this initiative, and we can probably walk to the next slide too. Um, as you are probably well aware, implementing evidence-based practices is really central and critical to California's goal of expanding access to and strengthening that continuum of care, and especially in the community-based behavioral health service realm. This is specifically targeted around individuals living with significant behavioral health needs. I think it's also important, and we've talked about BH Connect, but EBPs are really key components of both BHSA as well as BH Connect. And so in order to really support the evidence-based practice implementation, DHCS has established centers of excellence to really support practitioners in counties in implementing these EBPs. And they're actively supporting, developing requirements on training and technical assistance, fidelity monitoring, and data collection. They're also developing materials and will begin providing training and technical assistance and fidelity monitoring to counties and their providers under both initiatives. On the left side of this screen, you can see that we have 8 different evidence-based practices that are included and supported by centers of excellence under BHSA and BH Connect. There are a few that are evidence-based practices that are included under both initiatives. So you'll see that's ACT and FACT, CSE for FEP, IPS, as well as high fidelity wraparound. And then you have the 3 children, as well as clubhouse services that are covered under BH Connect. Next slide. So I mentioned that DHCS has selected and identified 3 centers of excellence to support evidence-based practices. And since we're going to be focusing on children and youth today, we'll go ahead and highlight the 3 here. MST Services will be the Center of Excellence for MST. FFT LLC is the Center of Excellence for Functional Family Therapy. And PCIT International is the Center of Excellence for Parent-Child Interaction Therapy. I mentioned that high fidelity wraparound does not have an established center of excellence yet. However, we do anticipate more guidance and an established center of excellence in Q4 of 2025. I think it's also important to note that MST, FFT, and PCIT are all covered under the early and periodic screening, diagnostic, and treatment requirements. And if you have any additional information that you want to have on each of these entities, feel free to reach out or connect to our COE resource hub. We'll also, as I'm sure you'll see with our Center of Excellence presentations, they also have their own websites that you're welcome to visit and find additional information. Next slide. Given the number of evidence-based practices and the multiple initiatives, it's important that implementation of these EBPs is really closely coordinated across both initiatives. You'll see that there's some shared features for the EBPs across BHSA as well as BH Connect, centering around implementation requirements, the access to training, and really workforce. Even though high fidelity wrap, MST, FFT, and PCIT are already covered under EPSD requirements, it's important to note that the core requirements are still going to be identical regardless of whether or not counties opt in to BH Connect to cover these services or if they maintain the current requirements. Next slide. So while we're just now hearing from the Centers of Excellence, this initiative started back in 2024. Each of the Centers of Excellence were selected in November of 2024, and we came under contract at the beginning of 2025. Soon after, the Centers of Excellence have all been establishing their training and technical assistance materials, but also the counties responded to a needs and readiness assessment in March of 2025. We were able to use the results of that survey, and each of the Centers of Excellence really established a statewide implementation plan that accounted for the county input that was submitted. In the coming months, and I think this is important on this slide, we're having the webinars currently in August. The engagement initiation form, which I'm going to detail the specifics of what this means for counties later on in this presentation, but the engagement initiation form is essentially the opportunity for counties to engage with the Centers of Excellence and establish a time for that initial consultation. So once those engagement initiation forms are submitted, and these can be ongoing, which again, I'll talk about that process in just a minute. Then county consultations with each of the centers of excellence can commence soon after that, and custom tailored training and technical assistance can be identified and rolled out following that consultation. Next slide. As you're aware, DHCS has released a lot of guidance related to evidence-based practices as well as the policy guide. You'll see these posted, I think pertinent for the children and youth. You'll see in June of 2025, they released a draft bin relating to coverage and payment and compliance requirements for MST, PCIT, and FFT. Final guidance will be released in the coming months following that public comment period. Additionally, you'll see on that last bullet there, DHCS is going to be releasing guidance supporting implementation for high fidelity wrap under both BHSA and Medi-Cal. So additional details about high fidelity wrap are forthcoming. Next slide. This is just another way to digest the information. You see where our webinars are scheduled here. Each of those webinars will have a recording placed on our COE resource hub. Additionally, anybody who attends will also get a recording as well as the slides in an email following the session. You'll see in upcoming, you have the public comment period for both the EBP training and fidelity standards as well as for the minimum service capacity. And then you also see the timeline for when the publication of both guidance for EBP as well as minimum service capacities is anticipated, which is happening in October. All right, now with that, we walked through an overview of the COEs, the roles, the current state. We'll definitely go through more details around the engagement initiation form and how to engage the COEs moving forward. But now we're going to hear from the children and youth COEs. So first, we're going to hear from Betsy Clipper with MST Services. So I'm going to go ahead and pass the spotlight over to her for a presentation on MST.
Thank you, Patrick. Hi, everyone. My name is Betsy Clipper, and I'm the MST COE manager for the California BH Connect project. So I'm going to go over a few slides about our Center of Excellence and the MST model and the training and technical assistance that you'll be getting if you choose MST. If you can change the slide, please. Thank you. Related to the California BH Connect project, we have a core leadership team at MST Services who'll be working with the counties and providers in California. Tom is our Director of Business Development. I, of course, am the CEO manager, and I'm the primary point of contact for this project. And then we've got Melanie, who is the Program Development Coordinator. She's also on this webinar right now. So I'm going to share a few highlights for those of you who may be unfamiliar with MST Services and the model over the next couple of slides. And I'll start with the initiation of MST Services. The randomized study of MST was done at the Medical University of South Carolina. And in 1998, we developed the multi-systemic or MST Services as the distribution arm. And we support teams all over the globe, currently several countries around the world. I'm going to review some of the research history and target outcomes in a few slides, but a key factor that I want to highlight here, a key factor for teams getting similar outcomes to the ones that were seen in the original randomized study of MST is the intensive quality assurance or QA process and the continuous quality improvement methods that we use in helping teams to implement MST with fidelity. And that the research shows us that leads to the high quality clinical outcomes that we're after. MST Services and our network partners currently support 643 MST teams around the globe. Next slide, please. As a Center of Excellence, we'll be working directly with county behavioral health agencies and the behavioral health practitioners. Once an EIF has been submitted by the county, we will be coordinating consultations with county leadership to provide information about training and technical assistance resources, helping determine the county needs and priorities, and then connect the behavioral health practitioners with an MST program developer and an expert consultant who will support the teams in startup and support the clinicians through training and technical assistance. Next slide, please. So a little bit more about MST. We're an evidence-based therapeutic approach that empowers at-risk youth and their families or caregivers to function responsibly over the long term. Our target population for MST is youth ages 12 through 17 who are at risk of severe consequences within the family, school, or community domains due to serious externalizing, antisocial, and/or challenging behaviors. Exceptions for youth aged 10, 11, and 18 can be approved by the team's expert consultant, provided the youth meet those inclusionary criteria. We understand that as the world goes on, some younger age youth we're seeing the same types of behaviors and the same type of contributors to the behavior that our model can be successful in working with them. So that can be assessed on a case-by-case basis. Our model is based on the causal model of youth antisocial behavior, and our service delivery model matches what the research shows are the common drivers to youth undesired behavior. So in that realm, we view the client as a network of systems, including the family, the peer system, the school system, the community, and of course the individual youth. So we're assessing the common and the specific drivers that are contributing to the particular youth's undesired behavior, and we match our interventions to what those contributors are. The average length of our treatment is 3 to 5 months with a target of 4 months, and all interventions are delivered in the youth ecology, at home, in the school, in the community, wherever the need may be. In the next slide, we'll look at the services that will be offered by MST Services regarding training and technical assistance. Through this BH Connect process, that will be delivered free of charge to the MST providers. There are 2 primary phases for the training and technical assistance. The first is the program development process, and our program developers work with the agencies to complete our program development method. Once a provider begins the startup process, they'll walk through a feasibility assessment to look at working with the stakeholders to identify how many clients are in need of the program, helping the agency complete all of the policies that are needed in order to support an MST program. Excuse me. And during that process, we help the agency set up what we call a goals and guidelines document, which is developed in collaboration with the agency's stakeholders to set down what the expectations are, what the outcomes are. We define what arrest means, for example, in each different county. That second step in that program development method is supporting the teams in recruitment, including the screening and the hiring of clinical staff for each team. And again, we're also helping the agencies coordinate meetings with their stakeholders. We really not only see the youth as embedded in their ecology, but also the team is embedded with their stakeholders, and we're all focused on the same desired outcome. Once an agency starts the MST program, then there's ongoing orientation. There's orientation and then ongoing training. We are a manualized approach. We have a manualized orientation that all clinical staff go through. That initial orientation is completed when the team is ready to begin seeing clients. It's a mixture of e-learning modules and then an in-person experiential classroom training. Our supervisors are also required to go into an orientation training as part of their new development, and that can be done either virtually or in person. Once the orientation phase is completed, we have weekly consultation with each of the teams that is conducted virtually, where the expert consultant is working with the teams to ensure the development of weekly treatment goals that are using our model to make sure we've got the best goal moving forward for each week. And then we also have quarterly booster trainings that are in person, where the expert consultant goes to the team and do trainings on implementing the model with more fidelity, or any of the interventions that we might use within the model. On the next slide, you'll see the requirements that an agency reviews and accomplishes during the startup process, the program development process. We want to make sure that the agency and MST services agree that the agency is able to and aligned with implementing the model with high fidelity. That MST program development process generally takes 3 to 4 months and will result in what we call a final report, which just outlines that agreement between the team and MST services. Fidelity to the model is very important for an evidence-based program, so we do have some standard measures that we use. We've got a therapist adherence measure that the caregiver fills out once a month to provide input on the therapist's use of the model, and importantly, the caregiver's learning of the model. We really want them to be learning what the therapist is doing, so that we've got that sustainability of treatment gains once we're gone. We've got a supervisor adherence measure that the therapists fill out on the supervisor every other month. Same objective, to get a measure and assessment of the supervisor's adherence. The research shows us that the more closely the supervisor is adhering to the MST supervision structure, the more adherent the therapists are in delivering the model. And the more adherent the therapists are to the model, the more likely we're going to have sustained treatment gains. We have a standardized discharge form that all therapists complete on a case. We've got a database called MSTI that each of the teams use, and that is reviewed with the therapist, the supervisor, and the expert consultant at case discharge. Because we're an evidence-based model, we have a commitment to continuous development that is focused on ever increasing our model implementation with fidelity. So this includes clinicians and supervisor development, as well as at the program level. The program implementation review, or PIR, is something that's completed every 6 months with the agency, the team, the expert consultant, and in collaboration with the stakeholders, to assess how the program is doing with implementing the model, highlight their successes, and of course, identify any growth areas to be worked on. The next slide looks at a few outcomes that I wanted to share with you. When MST is delivered with fidelity to the model, youth post-treatment demonstrates a number of favorable outcomes. Our target ultimate outcomes for all youth are 90% living at home at discharge, 90% in school and working at discharge, and have had no new arrests during treatment. There have been 103 published outcome, implementation, and benchmarking studies on MST to date. Across all of those studies, the median of 54% fewer out-of-home placements has been seen across all studies. We've also done a longitudinal study, 2 longitudinal studies on the youth that were involved in the first randomized trial of MST that established our short and long-term effectiveness with chronic and violent juvenile youth offenders. At 14-year post-discharge follow-up, 54% of those youth there's 54% fewer arrests of those youth involved in that first study. And at 22-year follow-up, 75% fewer violent felony arrests. So we're very excited about the sustainability of the treatment gains that we're seeing and that we continue to see. I encourage you to go to our MST website to get a more detailed summary of the research that was done. And of course, if you reach out to me, I can get you more information on the specific studies if you're interested. So that is MST. We look forward to talking more with you if you are interested in starting MST in your county. And now I will pass the spotlight over to Helen with FFT.
Great. Thank you, Betsy. And welcome everyone. FFTLC is excited to be a part of BH Connect. My name is Helen Meduis, and I am the Implementation Director for FFT LLC. And for this section, we're going to provide an overview of our Center of Excellence and our training and technical assistance approach for the FFT model. Next slide. So our team that will be involved with this Center of Excellence involves multiple members. First, we have Candace Seegers, who's our business development consultant, and works on the front end of the initiation of working with counties and providers. We have Holly DeMoranville, who is our communications director and is a point of contact for the counties. We have Kelly Army, who is our FFT National Clinical Director. Leah Rooney, who is our COE manager, and Brandy Morin, who is our COE implementation support analyst, along with myself directing implementation. For more information about our Center for Excellence, please feel free to visit the Center for Excellence Resource Hub, as well as the link to our FFT LLC website. Next slide. So a little bit about the background of FFT. It's been around for a while, founded in the 70s by Dr. James Alexander. This model was established as a disseminated model around 1998 when FFTLC was founded to provide training and technical assistance to the FFT model. Over the history of FFT, we have over 71 published and peer-reviewed outcomes, implementation, efficacy, as well as effectiveness studies. And we do have a large evidence-based training footprint, globally, with over 20 years experience in sustaining 350 plus teams across 45 states and different countries, working within different cultures, languages, ethnicities, and geographical areas in the world. And usually we work with about 50,000 families annually. Next slide. As a Center of Excellence, we will be working directly with county behavioral health agencies and the behavioral health practitioners. Once an engagement initiation form has been submitted by the county, we will coordinate consultations with the county leadership, provide information about training and technical assistance resources, determine county needs and priorities, and then connect the behavioral health practitioners with our FFT national consultants and trainers who will do the support for our teams and our clinicians through our training and technical assistance. Next slide. So FFT is a research-based prevention and intervention program for at-risk youth or adolescents and their families. Our model targets youth between the ages of 11 and 18. FFT is a clinical change model. It is not a case management model. So therefore, we're working with a population that can benefit from clinical change models. FFT serves both as a prevention program and a treatment intervention. So we work with a wide net of youth. For prevention and intervention, usually status offenses, diversion out of placement, kids who are starting to show at-risk behaviors, all the way to youth who are more moderate and seriously delinquent. And our goal is to keep them from further penetrating into those systems. We are a short-term family-based program. And so what really counts to us is the quality versus quantity, and having a model for therapists to be anchored in allows them to be able to match the model to the uniqueness of each family and move that family quickly to experience change and then help them with lasting change. We can deliver this in about 12 to 16 sessions for moderate cases, and we have the flexibility, of course, to go longer or more intensely for more serious cases. Again, always matching to the risk and protective factors presented by the team. The program is spread usually over 3 to 5 months. And we always deliver FFT where it's convenient for families. The goal is to remove obstacles to treatment. As a family-based model, we are a relational and a systemic approach, which means we don't do individual work. And part of our model, what is built into that model, is the ability to engage family members that are relevant in terms of that young person's life and develop and enhance those relationships. And FFT works with a range of adolescent emotional or behavioral concerns, risk factors that fall under violent behavior, drug abuse and use, conduct disorder, oppositional defiant disorder, all the way through to family conflict. For us, the family is our client, and so while we understand the adolescent referral behavior triggers that referral, we see that as part of a systemic behavior that lives within that system, and therefore our approach is to address it within the system that youth is in. Next slide. FFT has 5 phases. They are engagement, motivation, relational assessment, behavior change, and generalization. Each phase has its own assessment, goal, and intervention, as well as strategies. We start very much with creating a motivational context for change, helping that family feel hopeful, see the potential to change, and work along through alignment with that therapist. So we spend time in the beginning engaging and motivating families, as well as understanding functions of behavior and how family members get their needs met, moving into being more structured and more directive by addressing individual behaviors that are part of patterns, and giving families different ways of experiencing each other and relating, all the way up through the end of the model, which is generalization, which is a relapse planning phase, so that when the FFT therapist is no longer working with the family, that behavior change is able to sustain. As I said earlier, the sessions can vary depending on many different factors. We always move forward in the model, and it can, again, 14 sessions on average between 3 to 5 months. Next slide. FFT will be offering training and technical assistance for our FFT providers free of charge. And this is a bit of an ambitious outline of our training, but on a high level view, the first year, our focus, what we call phase 1 or year 1, is really that clinical training focus of adherence and competency in the model. Those are the 2 areas that make up fidelity, and developing accountability in terms of being able to deliver that model. We do a lot of work, pre-implementation and stakeholder work with the provider, moving into intensive clinical trainings that are ongoing throughout the first year. As I mentioned earlier, we connect our teams with an FFT national consultant who not only provides weekly consultation virtually, but also does ongoing training. Towards the end of the year, the team gets an advanced clinical training and a supervisor is identified. Our supervisors have to practice the model in the first year, and that supervisor goes to an intensive 3-day, 3-time externship to prepare for supervisor year or phase 2. Our teams always use our client service system, which I'll talk about in a second, and we offer administrative and technical assistance throughout the relationship with our providers. In year 2, we move into a site supervisor focus, meaning allowing that team to develop more self-sufficiency and accountability. Somebody from that team is trained as a supervisor and leads their peers. They continue to get consultation. There are ongoing training opportunities, and again, they have access to our web-based system and ongoing implementation administrative support. Year 3 and beyond are maintenance years, where we support that team to have ongoing adherence and competency through ongoing training and consultation for the life of the certification with that team. Again, always using our system and providing ongoing technical assistance as needed. Next slide. Our web-based system is a requirement and has been developed around the model to help therapists process the work they're doing. It also helps with the delivery of training and fidelity monitoring by our consultants or supervisors. Therapists enter all of their service delivery information, contacts, sessions, and all the assessments we use in the model. The CSS also allows us to provide feedback around meeting best practices and national standards. We have various tools. For example, a site status card really establishes a way for the team and the consultant to help them grow in those early phases of doing the model and help them to have success. And then as an ongoing feature, when they meet weekly for consultation, fidelity ratings and feedback are provided through weekly supervision checklists. And then periodically, approximately every 4 months, therapists on the team get global therapist ratings, which is really a nice way to give them performance and knowledge feedback with learning and growth plans. And then the whole team receives a tri-yearly performance evaluation, what we call a type report, that really looks at a status or almost like a health check for the team. And from this, we develop QI plans. Next slide. And to close, our expected outcomes in the FFT model, when delivered with fidelity, the model can have a number of favorable outcomes. And again, as a training organization, that is our goal and our role with our providers to help them be able to deliver that model with fidelity. We can effectively treat youth within that entire range of disruptive behavior disorders, interrupting the matriculation of youth into restrictive higher cost services, and reduce the entry into other systems like the juvenile justice system, the welfare system. And you can see here some of our outcomes across the youth that we work with. These are just some examples of evaluations to share with you. Next slide. Okay, I am going to pass the spotlight over to Melanie Nelson with PCIT, who will provide more detail on the parent-child interaction therapy.
Thank you, Helen. My name is Melanie Nelson, and I'm the Executive Director of PCIT International. And we are happy to be here to provide an overview of our PCIT Center of Excellence and our approach to training and technical assistance. Next slide, please. So our core leadership team for PCIT International includes myself as the Executive Director and Christina Warner-Metzger, who is our illustrious Project Director. And so if you need to reach out to us, we are good first points of contact. A little bit about PCIT International itself. It was founded by the developer of PCIT, Dr. Sheila Iberg, and we continue her legacy of over 50 years of research and clinical expertise. PCIT International is an international leader in large-scale dissemination projects, including statewide and nationwide projects in several countries. And certification from PCIT International has worldwide recognition with strong PCIT programs in countries like Japan, Korea, Australia, Germany, and New Zealand, among others. For more information about our COE, please feel free to visit the COE Resource Hub or our PCIT International website at www.pcit.org. Next slide, please. So similar to our colleagues from FFT and MST, as our Center of Excellence, we will be working with both the county behavioral health agencies and the individual behavioral health practitioners. Once that engagement form has been submitted by the county, we will be reaching out to coordinate meetings with county leadership and therefore start to provide our training and technical assistance resources, determining the county's needs and priorities, and then connecting the behavioral health practitioners with our experienced PCIT training team who will support the clinicians throughout the training and continued technical assistance. Next slide, please. So PCIT is a research-based, family-oriented therapy aimed at changing parent-child interaction patterns to address a variety of presenting concerns. PCIT was originally developed as an intervention for children with disruptive behavior, so those that are uncooperative, aggressive, destructive, and sometimes being kicked out of places like daycares and preschools and kindergartens. Over the years, the PCIT research base has really been extended to additional child populations as well, including children with ADHD and autism, those with a history of trauma, and those with more severe internalizing symptoms such as anxiety or depression. Our target population is youth between the ages of 2 and 7, but in all of our practice, we work with the caregiver and the child together as a dyad. And the treatment is considered relatively short term, on average about 16 to 20 sessions, which are generally held in weekly hour-long appointments. The 16 to 20 sessions, like I mentioned, is on average. This length of treatment is titrated to the family's needs and the child's response to treatment. Treatment itself is divided into 2 phases, with the first phase known as the child-directed interaction, or CDI, focusing on increasing the amount of positive reinforcement the child receives for desired behavior, whereas the second phase, the parent-directed interaction, or PDI, focuses on helping parents address undesired behaviors and set appropriate limits with their child. What sets PCIT apart from other models is how the sessions are structured. The majority of our PCIT sessions are conducted as what we call coaching sessions, where caregivers are practicing the PCIT strategies that we've taught them as they play with their child, and they receive live coaching from their therapist via a bug in the ear. And I like to joke that when PCIT was originally developed 50 years ago, the idea of a bug in the ear was very high tech and fancy. And nowadays it's just a Bluetooth earphone that we all use. But it still does the job, and we are happy for it. This approach really does allow caregivers to learn how to use the strategies in the moment with their child in a way that's going to be tailored specifically to their child and their family. Next slide, please. So our approach to training and technical assistance is designed to really support the development of strong and sustainable PCIT programs throughout the state, so that ideally any family that may benefit from PCIT has the ability to seek out PCIT locally to them. In order to meet this goal, we're working with agencies to develop a comprehensive implementation plan and provide that technical support that might be necessary to address how PCIT can fit within their agency's site and culture. So as we create this implementation plan, we will be discussing plans for infrastructure, materials, space, workforce, leadership engagement, and measuring outcomes. And we really consider the implementation aspect a very important part of the process. And so a lot of that will take place before the training of therapists happens. We are anticipating beginning trainings starting in this fall. And we have a variety of trainings that we're offering so that we can work with each behavioral health agency to create that sustainable program. So we have, of course, the initial therapist trainings for those that are very new to the model. And that is followed by consultation and fidelity monitoring over time. We also are offering what we're calling next step trainings, which are advanced trainings for therapists that are already certified or trained in PCIT to further build their skills. And we are offering within agency trainer trainings for advanced PCIT providers who are eligible to become trainers. And then the final step in the trainer series would be to be trained as a regional trainer, which would be somebody who's currently with an agency trainer and is qualified to become a regional trainer to train outside their own agency and across the state. We're also offering senior leader trainings to work with the key agency decision makers and stakeholders so that everybody within that system understands the treatment itself and how to create that successful, sustainable program. Next slide, please. So this slide breaks out the different types of training a little bit differently based on who they're designed for. So that technical assistance is for everyone, and we anticipate that the technical assistance phase, the preliminary technical assistance phase, will take approximately 3 to 6 months before training for agencies that are new to PCIT. And this is both individualized and group-based. And it's always going to be titrated to the need of that particular county and agency. Those that have already a PCIT team up and going, it may be very much shorter than that. For those that have significant barriers to implementation, it might be a little bit longer than that. As I mentioned, the next step training is really that advanced training to build the capacity for PCIT providers to promote ongoing fidelity to the model over time and ability to implement PCIT with additional populations. As I mentioned before, the initial PCIT therapist training is exactly what it sounds like. It's for providers who are brand new to PCIT. And once they've received the initial therapist training and achieved certification there, they would be eligible for training as a within agency trainer that allows certified PCIT providers to be trained to train others within their site so that it can create that sustainable program. And then experienced within agency trainers can train towards being a regional trainer, which would allow them to train not just within their agency, but across their county and across the state. And then we plan to offer additional trainings in terms of continuing education opportunities, quarterly webinars, and a biannual booster training, again, for PCIT therapists to continue to build their skills and promote fidelity across time. Next slide, please. So we have a variety of data that we will be receiving from both the therapists at the client level and from the trainers at the therapist level. The client level data is received for the purpose of the consultation that they receive so that we understand what's going on with their cases and can provide them with timely and effective case consultation. But it also assesses treatment fidelity in terms of making sure that they are doing the aspects of the treatment. Like some of the other models, we have a manualized treatment, and there's certain expectations for each session. The treatment fidelity is also measured by that training fidelity and attainment of treatment competencies, and we receive that data from the trainers. All of the trainees are expected to meet certain competencies in order to be able to implement PCIT with good fidelity to the model. And we plan to collate this data and then share that data with HMA and DHCS in terms of documenting the fidelity of the implementation process. Next slide, please. And then we know when PCIT is delivered with good fidelity to the model that we see a number of favorable outcomes for the child and honestly for the caregiver as well. Even though the child is our identified client, we too really value the system that the child is functioning in. And when the caregiver is functioning better, the child benefits from that as well. And so we see sustainable and large improvements in child behavior. Families that are successfully graduated from PCIT are reporting that their child's behavior is within normal limits at the time of graduation. We also see results related to reduced parental stress, and even particularly for moms, a reduction in their reporting of depressive symptoms from pre-treatment to post-treatment. Caregivers that go through the PCIT program also report increased confidence and a use of more adaptive parenting skills. I will now pass the spotlight back to Patrick Metters with HMA to go through the final slides that highlight the next steps and the COE engagement opportunities.
Great. Thank you, Melanie. And thank you to everybody for your presentation. I did want to highlight, we do have, it looks like we have 13 questions that have come through the Q&A function there. So I know we have nearly 300 folks on this call. So if there are any additional questions that you want to make sure that HMA or the COEs and DHCS answer on next week's Q&A session, please make sure to drop that question in the chat. Even if you're not getting an answer today, you will get an answer by that Q&A session next week. So I know the large question here, and we've heard from the COEs, we understand that the training and technical assistance, as well as certification and fidelity monitoring, is all free of charge for those providers who are contracted with the county or county operated. So really the next question is, well, how do we get engaged? So let's walk through what that process looks like, just so everybody's on the same page. When you think about the engagement initiation form, this is essentially the county is, and I will preface this by saying the county BH director or a designee specific for that EBP within the county will be the one submitting the engagement initiation form. That initiation form has all 7, actually 8 evidence-based practices listed on it. And essentially, the county can select one of those, or it can select all of them at one time. What I would encourage is if a county is interested, and I think some of the questions come up is like, when do we know when to submit? If a county is interested in implementing an evidence-based practice and is ready to engage with the Center of Excellence about next steps, that is when an engagement initiation form really should be submitted. And, especially if you're thinking within the next 3 months, you'd like to have that consultation with the Center of Excellence, that's when it should be submitted. Now, if you're looking at next year is when you would like to implement the evidence-based practice, we can hold off on the engagement initiation form. It's really that 3-month time frame. What I will say is that I would prefer, and I would probably recommend that if a county is interested, I would submit an EIF form sooner rather than later. If everybody waits, obviously timelines get compressed, and then you'll also see schedules becoming a bit more challenging to navigate. Once an engagement initiation form has submitted, so let's say a county's ready to start with PCIT International, they'll submit an engagement initiation form, select PCIT International. HMA will receive a notification of that, and we will be responding within 1 day to the Center of Excellence to let them know that we have received a form. Within 3 days of that email, a COE will be reaching out to the county to make sure that we're essentially a welcome email and to start scheduling the consultation with the Center of Excellence. We also recognize that one consultation may not be sufficient, as a county may require multiple consultations or engagements as they start to craft a tailored TTA plan for their county. So while it's one engagement initiation form, there's one follow-up consultation, there could be additional engagement that will occur after that initial assessment. We have a link here, but I did also want to make sure I specify these consultations are available anytime. So if you're ready to start tomorrow or as soon as possible, go ahead and submit the engagement initiation form, and a COE will respond within 3 business days. Next slide. Now, I mentioned the consultations. This is what you can expect when you think about what might be included in a consultation. These will be held either virtually, one-on-one, or in small groups, depending on the geographic location and the need. But these are the types of things that a Center of Excellence might go over related to their specific EBP. So as you think through a consultation with them, if you're ready to speak to some of these timelines or speak to some of the resources or referral sources or even what your needs may be, that would be a perfect time, obviously, to engage the COE. I think the other thing, obviously, a lot of these services have been in existence. And so the county is already aware of many of the contracted providers that are included in their network. And so that can be a good caveat for what you should know heading into that consultation and just knowing what to follow up on. So in terms of next steps, so we have the engagement initiation form, you'll get a consultation, and that essentially starts the engagement with the Center of Excellence. Soon after that, that is when the Center of Excellence will start working with the county contracted or county operated providers and practitioners as it relates to the training and technical assistance. And just a reminder, that means the training and technical assistance and certification is free of charge to those entities. So at this point, let's walk through the next steps in terms of what the engagement will look like for the other centers of excellence. We do have a question and answer session. So again, all the questions that came through today will also be answered at next week's question and answer session at 1 o'clock on the 14th. Everybody who registered today was automatically registered for the Q&A session next week. Additionally, we will have a live session. So if you join that call next week, there will be a live session. So any questions that you do ask during that time will either be answered live or also logged and responded to in writing. Additionally, if you want to go to the next slide, HMA and the Centers of Excellence will be coordinating a monthly office hours. The primary goal of this is to really review a variety of topics, including those that are coming through via email or in these question and answer sessions. It's going to be an opportunity for really the counties to share best practices and insights and really learn from each other. Additionally, there will be a lot of topics that may be pertinent across multiple counties or may be specific to a certain EBP. And so we'll focus a lot of these office hours around what we hear from you. Additionally, these are going to be offered on a once-a-month basis, but we've already heard that it may be helpful to offer these more than once a month. And so we will look into evaluating kind of the need of the monthly office hours and the utility of it, as well as ensuring that that multiple ways of conveying this information is available for the counties and the providers. If there's continued interest after the holidays, we'll start back up in January. And again, we can increase the cadence if needed. I should also mention that any questions that come through, if we're starting to notice themes across specific EBPs or across the centers of excellence, those will likely make their way into a frequent asked question document that we will be having on the COE Resource Hub. So as we start to hear from you and start to have questions come through, we'll make sure to answer those questions and post them on our website as well. Next slide. So that resource hub that I mentioned, that is going to be your one-stop shop. So if you're ever wondering what the latest updates are, if you want to get more information about the evidence-based practices or the centers of excellence or what's forthcoming, go ahead and visit our COE resource hub. We've dropped that link in the chat, I think, multiple times. We also encourage you, we are going to be producing a newsletter as well that we'll be sending out and providing additional information. So just another way for you to get the latest information related to the Centers of Excellence and the evidence-based practices. So make sure to sign up for that newsletter as well. And as always, you're welcome to submit any questions you have to that email address listed there. Any questions that come through that are logged and triaged accordingly, and you can expect a response to each question that is submitted. Okay, and I think with that ends our presentation. So first, let me say thank you for everybody who has attended the webinar today, and I hope that you've been able to get some additional information. Please make sure to drop any questions in the chat, and if you haven't submitted something or want to submit something later, feel free to send an email to us, and we'll make sure to address it in next week's session. Thank you again for attending, and we'll see you all soon.